Hello again, it's Dr. Debbie Morris, and today we're going to go into a good deal of detail about some of the parts of the endocrine system that we've talked about a little bit in the last lecture. So we're going to talk about the thyroid gland, the parathyroid glands and hormone, how calcium levels are controlled, which is including parathyroid gland, but also vitamin D. And we'll talk about the adrenal gland, and particularly about the adrenal cortex. So these are our goals for today, and it's talking about the anatomy and products of the thyroid gland, the parathyroid gland, and the adrenal glands, also called the suprarenal glands. We'll also talk about the functions and understand disorders of the thyroid, the parathyroid, and the adrenal cortex. So let's start with the thyroid and parathyroid glands. The thyroid gland is a bilobed gland that sits in the anterior neck and partially surrounds the trachea. It's below the cricoid cartilage. It's somewhat mobile. If you look at this picture, it looks like it's attached to the trachea, but it's actually separate from the trachea and moves when we swallow. The parathyroid glands are immediately posterior to the thyroid gland. The picture shows them as being anterior. The thyroid gland produces two hormones primarily. One of them is called T4 or L-thyroxine, so levothyroxine or just thyroxine, and the other is T3 or levotriiodothyronine. These hormones are extremely important in regulating metabolism, growth, energy expenditure, cellular respiration, maturation of tissues, other hormones and substrates, and turnover of those and of vitamins. Within the thyroid gland, there are clusters of something called follicles, and they are enclosed within a capsule that is surrounded by very high blood flow capillaries. When we look at the thyroid gland, we would say that a follicle is the structural and functional and secretory unit of the thyroid gland. So the follicle is the functional unit of the thyroid gland. The follicles have cells that are surrounding a glycoprotein that is called colloid. So colloid is thyroglobulin and prehormone and iodide, and it is surrounded by the thyrocytes or thyroid producing cells of the thyroid gland. And we'll show you some pictures and talk about that in a little bit more detail. There are a number of enzymes that are produced in the thyroid gland. One of them is thyroperoxidase, and it's synthesized within the thyrocyte using the cellular machinery of synthesis, and it is important in oxidizing iodine. And oxidized iodine is crucial to make these two thyroid hormones, T3 and T4. The iodine is moved into the thyroid cells by a sodium iodide symporter. So sodium is moving down its concentration gradient because of the action of the sodium potassium ATPase, and it is carrying with it iodide out of the extracellular fluid and into the cells. And if you look at thyroid hormones, the iodine is a critical component and comprises more than half of the weight of a given thyroxine or triiodothyronine molecule. The glycoprotein in the colloid, thyroglobulin, is the substrate for the hormones. And once the hormones are made, they are stored in the colloid. T3 is the active form of thyroid hormone, and T4 can act, but it is much less potent. So T3 has about 3 times the potency of T4. It has a short half-life, and once in the blood, it's considerably shorter than T4. So what is T4? It's essentially a prohormone, a storage hormone that is stored in the thyroid gland and in the tissues in the cells, and can be broken down to form T3 as needed. So T4 has a much longer half-life, both in circulation in the cells and in the gland. And here we have a really nice illustration of a portion of a follicle. So here is our follicle. It is surrounded by thyrocytes, or thyroid follicular cells. There is a capillary bed, which is very active. The thyrocyte is a metabolically extremely active cell that has obviously a nucleus and endoplasmic reticulum and Golgi apparatus. The iodide that's circulating from dietary sources, and one of those dietary sources is seafood, things like seaweed and iodized salt in places that are far from the sea. So the iodide moves into the cell as a secondary active transport in association with sodium ions. The iodine is then moved into the colloid, and in the colloid it's oxidized to iodine and combines with tyrosines to form diiodotyrosine and monoiodotyrosine. So these are iodinated tyrosines. And the iodinated tyrosines get linked together to make T3 and T4. And the 3 has to do with the number of iodine molecules that are attached to the hormone molecule. When needed, the T3 and T4 that are stored in the colloid get taken up by endocytosis, combined with a lysosome that cleaves the hormone molecules from this colloid material, the thyroglobulin. And then the hormones diffuse across the cell membrane into the bloodstream, where they travel to virtually every tissue in the periphery. Thyroid hormone is continuously made, but it is also stored within the gland, and there is about a 3-month supply of T3 and T4 stored in the thyroid gland. If suddenly synthesis stopped, perhaps because the supply of iodide ceased, there wouldn't be an appreciable change in circulating thyroid hormone for at least a couple of months. As the need arises, T4 and T3 are endocytosed by the cell, cleaved from the thyroglobulin by the lysosomal enzymes, and released into the bloodstream. So you can see that a lot more T4 is made and released than T3, but T3 is the active hormone. There is a circulating protein made by the liver called thyroxine binding globulin. There are other proteins like albumin to which T3 and T4 can reversibly bind. So most of the hormone that's circulating in the blood is protein bound. There's a little bit that we call free thyroxine or free T3. This binding, while it's reversible, is pretty high affinity. So the hormone that's circulating is relatively slowly released to the tissues. T3 binds less avidly and is more quickly released than T4. And then the T3 and T4 can be bound within the cell to proteins within the cell and further stored. So, because of the large supply of thyroid hormone in the gland and the protein binding in the blood and the local storage in the tissues, these hormones have a very slow onset and a very long duration of action, so days to weeks for T4. Within the cells, most of the T4 gets converted to T3. The thyroid receptors are on the nucleus of the cell. So there are nuclear thyroid hormone receptors that bind primarily T3, again, the active hormone. And that T3, through mediators, activates the transcription of DNA and results in an increase in protein synthesis. So, in every tissue, thyroid hormone is part of what is activating nuclear genetic transcription to make things like enzymes and structural proteins and transport proteins. You need thyroid hormone to support the activity of metabolism, and it is particularly important in increasing carbohydrate and fat metabolism. When we have inadequate thyroid hormone, cholesterol levels go up, lipid levels go up, and atherosclerosis is promoted. So, one of the long term effects of hypothyroidism is atherosclerosis and potentially coronary artery disease and peripheral arterial disease. When there is excess thyroid hormone, we have increased metabolic activity and often weight loss, sometimes a slightly higher body temperature, more oxygen use. These people breathe a little more rapidly, and they have increased vitamin requirements because they're metabolizing things more quickly. In addition to an increase in heart rate and in cardiac output, I mentioned an increase in respiration. People with excess thyroid hormone may also have an increase in GI motility. So, hyperthyroidism results in tachycardia, tachypnea, potentially cardiac arrhythmias, and sometimes diarrhea. Thyroid hormone has effects on cognition and thinking, on cerebration, and on sleep. So, people who are hypothyroid tend to be slowed down, have more difficulty with cognitive functions, maybe sleep more. People who are hyperthyroid or have excess thyroid hormone are sometimes find their minds racing and can't sleep. And one of the very important things to know about thyroid hormone is that it is extremely important in fetal and infantile brain development. So during prenatal life and infancy, if there is inadequate thyroid hormone, irreversible brain dysfunction can result. This diagram is showing the action of thyroid hormone, including the transport proteins in the capillary that are carrying hormone, free hormone that is either traveling unbound or released from the transport protein. These hormones, tyrosine based hormones, are lipid soluble so they can diffuse into the cell, where they can be stored on cellular proteins or they can bind to nuclear receptors. The receptor hormone complex promotes the transcription of genes and the expression of specific genes, resulting in increased messenger RNA and synthesis of proteins on ribosomes. So here we show a ribosome with the messenger RNA synthesizing a strand of protein, and these proteins do things. They act as enzymes, they act as structure, but they alter the activity of the cell. And this diagram is virtually the same, but it's also showing that in addition to the nuclear receptors, there are receptors on the mitochondria that increase ATP production and increase the metabolism of lipids and carbohydrates, again changing the activity of the cell along with this increase in translation and protein transcription, translation, and protein synthesis. So, you remember when we talked about anterior pituitary control of the thyroid gland, that the hormone that triggers activity in the thyroid gland is thyroid stimulating hormone, or TSH. So TSH increases thyroid hormone production and secretion. It also acts as a growth factor for the thyroid gland. There is a secondary messenger for the activity of TSH in the thyroid cells. So that TSH binds to TSH receptors, which trigger the activity of this cyclic adenosine monophosphate, which acts as a secondary messenger, which acts as a secondary messenger. There are some things that environmentally change TSH production. So when we are cold, we make more TRH, thyroid releasing hormone, or thyrotropin releasing hormone, I think, which stimulates TSH production, thyroid stimulating hormone, which stimulates T3 and T4 production, which increases metabolic activity to make more heat. Anxiety and excitement both decrease TRH and TSH and T3 and T4 production. And if you remember the feedback loops, there is a negative feedback of thyroid hormone on both the hypothalamus and the pituitary gland. So when thyroid hormone goes up, TRH goes down and TSH goes down. When thyroid hormone goes down, TRH goes up and TSH goes up. When we are making excessive thyroid hormone, or when we are taking in more exogenous thyroid hormone than we need, we get a low TSH. And conversely, when we are not making enough thyroid hormone, we have a high TSH. So let's talk a little bit about some of the disorders of thyroids. The first is something you've heard about and probably not seen a lot of, and it's called a goiter. A goiter just means an enlarged thyroid. Sometimes it's just large enough to feel or see, and sometimes it's quite massive. In a large part of the world, when you get far from seas and people are not consuming seafood or sea products and are getting inadequate iodide in their diet, they have low thyroid hormone production, right? Because thyroid hormone is very dependent on that iodine component. If you're not taking in iodide, you don't have the iodine, oxidized iodine, to make T3 and T4. And if you're not making enough thyroid hormone, your TSH goes up. And if you remember in the last slide, I think I said TSH, in addition to stimulating hormone production, acts as a growth factor. And therefore, the thyroid, under this constant unopposed action of TSH, just gets big. It's not able to increase thyroid hormone production, so it's sort of a vicious cycle. And this is why in the, I think, 20th century, we started iodizing table salt so that people who lived away from the sea and didn't get iodide in their diet in other ways would get it through using commercial table salt. There are other reasons for goiter, and when you see a goiter, it's unlikely to be from iodide deficiency. That's just not common in our world, but it is likely to be from another condition that causes hypothyroidism, thereby increasing, because of low thyroid hormone levels, increasing TSH production from the anterior pituitary, acting as a growth factor and making the thyroid enlarged. There are some drugs that can contribute to goiter, and there are some foods that can contribute to goiter. When we have excess thyroid hormone production or intake, because we can have excess intake from exogenous thyroid hormone, that can lead to weight loss, to tachycardia, to tremors, insomnia, anxiety, diarrhea, all of those things. And there are a number of things that can cause hyperthyroidism. A common one is exogenous hormones. So sometimes people are taking more thyroid hormone than they need and become hyperthyroid. When this happens, if you checked a TSH, would it be high or would it be low? So taking in excess thyroid hormone, the TSH will be low. So I'm going to tell you a PA story. I had a PA working for me at my MedX clinic in Fayetteville who was a great guy, good PA, had worked in the Army, did mostly administrative work in the Army. So he worked at the urgent care to keep up his skills. And I saw a woman one day who had seen him twice. She had come in, he had checked a TSH. Her TSH was low, so he increased her thyroid hormone, her levothyroxine, her Synthroid. And she came back feeling a little racy and tacky and anxious and sweaty and sleepless. And he checked her TSH, and her TSH was low, and he increased her Synthroid again. And the third time she came back and saw me, and clearly she was on way too much Synthroid. We cut back her Synthroid, got her TSH back in a normal range. And I talked to my PA, who kind of hit himself in the head. He hadn't seen anybody with thyroid disease for a while, and he had just gotten confused. He never did it again. Another cause of hyperthyroidism, and this is a relatively common cause, is an autoimmune disorder called Graves' disease. And in Graves' disease, the body makes antibodies that actually look like TSH to TSH receptors, and they also bind more strongly to TSH receptors than TSH does. They're called thyroid stimulating antibodies, or TSI, and when that happens, the thyroid gland just gets turned on and is not going to respond to signals from the brain, like lower from the pituitary, like lower TSH. So the thyroid is just turned on, full on, all the time, and the individual becomes hyperthyroid. If you were to draw blood and check a TSH, would it be high or low? and it would be low because all of that excess thyroid hormone is feeding back to the hypothalamus and the pituitary and shutting down the production of TRH and TSH. Doesn't help because the thyroid stimulating immunoglobulins, antibodies, are bound to the TSH receptors. Another cause of hyperthyroidism is an adenoma, usually benign tumor that is functional and not under the normal control of the regulatory mechanisms and homeostatic mechanisms like TSH. So if you have a functional nodule, which would be called a hot nodule, that's taking up a lot of iodine and secreting a lot of thyroid hormone, you can become hyperthyroid. If you were to draw blood and check a TSH, would it be high or would it be low? And again, it would be low because all of the excess thyroid hormone being made by the adenoma is feeding back to the hypothalamus and the pituitary and decreasing TSH production. And then the final cause of hyperthyroidism that we'll talk about here is a rare condition where an adenoma or glandular tumor, again, usually benign from the sense of not being cancer, occurs in the pituitary and produces excess thyroid stimulating hormone. And when you produce excess thyroid stimulating hormone, you're going to overstimulate the thyroid gland and make a lot of thyroid hormone. In this case of hyperthyroidism, if you drew blood and checked a TSH, would it be high or low? And by definition, it would be high because it's TSH that's causing the hyperthyroidism in this case. This is a picture of a patient with Graves' disease. There are a couple of things you can see here. Her thyroid maybe is a little enlarged. Her neck looks kind of thick. You can see this butterfly-shaped gland. Her eyes are protruding, and that is from a couple of reasons. One is excess sympathetic stimulation through the third cranial nerve so that her upper lids are wide open. But in addition, there is a deposit of material that causes the eyes to protrude. And you'll learn a lot more about this in your endocrinology course. But Graves' disease can be quite a serious disorder. It's treatable, and the ways we treat it usually initially are with some combination of treating the symptoms by using things like beta blockers to slow the heart rate. And there are drugs that are anti-thyroid and turn down thyroid hormone production and counteract thyroid hormone. But ultimately, it's treated by destroying the thyroid gland. And that's done either by giving radioactive iodine, an iodine isotope that is taken up by the thyroid gland and kind of by local radiation therapy kills those cells so that the thyroid goes away, or occasionally by surgically removing the thyroid, although that's much less common in the current era. That sounds terrible, right? Because the thyroid's very important. But it is easy to replace thyroid hormone. And so the treatment of Graves' disease is to ablate or remove the thyroid, wait until TSH levels get high, and then replace with adequate thyroid hormone, exogenous thyroid hormone, to return the person to a euthyroid, normal thyroid state. Hypothyroidism, or decreased thyroid hormone production, results in weight gain, often in swelling of the face and the eyelids, which is called myxedema, fatigue, often dry skin, coarse hair, and slowed cognition. The causes, and the most common cause in the United States, is something called Hashimoto thyroiditis, which is an autoimmune disorder in which the thyroid gland fibroses and loses the ability to make thyroid hormone. But other causes of hypothyroidism can include iodine deficiency, and so that happens in parts of the third world where people are unable to get adequate iodine in their diet. Surgical removal of the thyroid, which is sometimes done for thyroid cancer or for goiter. And there are congenital causes of hypothyroidism that we'll talk about in a couple of minutes. If we were to draw blood and check a TSH, would it be high or low? And in these cases, TSH is going to be high because there is inadequate thyroid hormone feeding back to the hypothalamus and the pituitary. So TRH and TSH go up to try to force the thyroid back into activity. Would you expect the thyroid gland to be small or large in Hashimoto thyroiditis as a cause of hypothyroidism, or an iodine deficiency as a cause of hypothyroidism? Well, TSH is high, and TSH is a growth factor that promotes the growth of the thyroid gland, and so you'd expect the thyroid gland to be big for this person potentially to have a goiter. And the treatment of hypothyroidism is simply to give exogenous thyroid hormone. In the old days, it was actually Armour thyroid, which I believe was ground up pig thyroid glands that were standardized to contain a standardized amount of thyroid hormone. But in the current era, most often people are treated with synthetic thyroxine, which is called Synthroid or levothyroxine. This is an image of a child with congenital hypothyroidism, which has become considerably less common. It is often from a lack of the thyroid gland to develop in the fetus. During fetal life, the mom's thyroid hormone can maintain normal growth if the problem is thyroid agenesis. In some cases, there are issues with thyroid receptors or enzyme deficiencies that can actually cause abnormal development during fetal life. But in most cases at birth, the kid's asymptomatic because they're getting maternal T4. They may have some abnormal development. They may be post mature. So these are the babies that go to 42, 43 weeks, 44 weeks. And if untreated, will result in problems with growth and brain development that are again irreversible. You have to treat immediately. So this is in some parts, many parts of the world, it's the most common preventable cause of developmental delay and cognitive problems in children. In the first world, every baby is screened immediately after birth for a large number of conditions, but one of them is hypothyroidism by checking TSH. So sometimes from those heel sticks, you've seen babies get heel sticks. And most often the primary test is a TSH with a backup T4 level. In other cases, they check a T4 with a backup TSH level to make sure that the infant has a normal production of thyroid hormone. And I thought I swear I changed this. I changed it twice, but I'm having trouble with my computer today and saving things. So it's no longer called cretinism. That's an obsolete term, but the term cretinism used to describe congenital hypothyroidism. It's become a pejorative term, kind of meaning idiot, and it's no longer used. So we'll probably have lots of other small issues here with things that weren't saved. But we're going to move on to the we're going to move on to the endocrine control of calcium and phosphate because calcium homeostasis is extremely important for normal function. There is quite a lot of calcium and phosphate in the human body. Most of it's stored in bone as a compound called hydroxyapatite. So calcium and phosphate and hydroxyl groups. And the rest of the calcium and phosphate are throughout primarily the extracellular fluid compartment with some in the intracellular fluid compartment, particularly phosphate. And they are in both organic and inorganic forms. There is calcium within the cells, but it's sequestered in the endoplasmic reticulum in the Golgi apparatus and in the muscle in the sarcoplasmic reticulum because calcium ions released from the sarcoplasmic reticulum are extremely important in muscle contraction. I believe we talked about that when we were talking about cardiac muscle. The extracellular fluid calcium, the circulating calcium, about half of it is protein bound and the rest is ionized or called free calcium. And the extracellular calcium ion concentration is much higher than the intracellular calcium ion concentration. When calcium levels are low, we get abnormal excitation of the muscles with spasms and tetany, and that includes cardiac muscles. So, very low calcium leads to cardiac arrhythmias and dysfunction. Very high calcium levels lead to lethargy and confusion. It's interesting that the levels of phosphate and calcium in the blood are pretty similar. Calcium is very tightly regulated, phosphate less so, and a lot of the phosphate regulation sort of follows the calcium regulation. Some of the regulation of these ions occurs in the kidneys, and we'll talk about it, but the renal threshold for reabsorbing phosphate is really important in maintaining the steady state. So, how do we do that? Well, behind the thyroid gland, there are four small parathyroid glands. They're behind the upper and lower poles, the left and the right lobes. So there are four of them. They look a lot like a thyroid gland lobule, so they're a little hard to locate. And when a surgeon is doing a thyroidectomy, one of the things that they try to do is locate and preserve as much parathyroid tissue as they're able to. When inadvertently the parathyroid glands are damaged or removed or their blood supply is interrupted, the patient post-surgically will get severe hypoglycemia and their muscles will freeze and they may have cardiac arrhythmias, all of those things. The cells in the thyroid glands that make parathyroid hormone, which is also called parathormone, are called chief cells. And on my next slide, the picture's not here. So I think I just opened the wrong presentation, the older unsaved presentation. I apologize for that. So when there is excess parathyroid hormone, calcium levels go up. And when there is inadequate parathyroid hormone, calcium levels go down. So parathyroid hormone excess leads to hypercalcemia, and parathyroid hormone deficiency leads to hypocalcemia. It does that by receptors in bone cells. So when parathyroid hormone is released, it interacts with bone cells to cause breakdown of bone and resorption of bone. And there are PTH receptors on the osteocytes and the osteoblasts and the osteoclasts. And we'll talk about those more when we get to our musculoskeletal physiology lecture. But when bone is broken down into the components of that hydroxyapatite, we end up with calcium and phosphate circulating in the blood. The other things that parathyroid hormone do is that it acts on the kidneys to increase the reabsorption of calcium. So calcium is removed from the lumen and put back into the extracellular fluid. And there are also PTH receptors in the gut that increase the absorption of calcium and phosphate in the intestine. So parathyroid hormone works to increase calcium levels by breaking down bone, by saving calcium in the kidney, and by absorbing more calcium in the intestine. This is just a little graph showing an infusion of parathyroid hormone. So we're at steady state, and at 1 hour we infuse parathyroid hormone. Over the next several hours, calcium levels go up, primarily from bone breakdown, but also from kidney reabsorption. And phosphate levels go down, and that is primarily from calcium reabsorption leading to an increase in loss of phosphate in the urine. What controls the release of parathyroid hormone? Well, not surprisingly, it's a negative feedback loop that is governed by the concentration of calcium ions in the plasma. So if calcium levels are high in the plasma, we make less PTH. And if calcium levels are low in the plasma, we make more PTH. There are receptors in the parathyroid chief cell membranes that detect changes in the calcium concentration in extracellular fluid and turn the hormone producing mechanisms on and off. This is a slide showing the effects of parathormone on bone and in other places. So on bone, parathyroid hormone stimulates bone resorption. So osteoclasts are the cells that break down bone. The parathyroid hormone binds to osteoblasts, causing an increased production of osteoclasts, which then go and chew up bone, releasing the calcium and the phosphate into the extracellular fluid. And therefore, calcium levels go up. And those higher calcium levels, remember, have a negative feedback onto parathyroid hormone. This slide is showing the parathyroid glands with hypocalcemia, low blood calcium levels, stimulating the production and release of parathyroid hormone. That parathyroid hormone travels to bone, where it activates the osteoclast, releasing calcium and phosphate into the blood. It acts on the intestine, where it increases calcium and phosphate absorption from food. And it acts on the kidney, where it does a couple of things. I've mentioned that it increases the reabsorption of calcium, but it also promotes the activation, the production of active vitamin D3. And vitamin D3 is also important in triggering an increase of calcium absorption from food. We'll come back to vitamin D3 in a minute, but I want to talk for just a second about another hormone that is actually produced not by the parathyroids but by cells in the thyroid gland called calcitonin. Calcitonin is not as important in humans as it is in some lower animals, and fish in particular, I'm aware of. But it is a peptide hormone. It's produced in cells in the thyroid that are called parafollicular cells. So they're not thyrocytes. It's a small proportion of thyroid cells. And calcitonin has sort of the opposite effects of parathormone. It decreases plasma concentration of calcium and opposes parathyroid hormone. It inhibits the effects of osteoclasts in bone, so it prevents the breakdown of bone. And therefore, it's actually used therapeutically to treat osteoporosis, also to treat hypercalcemia. And it's used as a nasal spray that's derived, it's a calcium calcitonin. It also inhibits the reabsorption of calcium in the renal tubules and allows both calcium and phosphate to be excreted in the urine. It becomes more important during pregnancy because it's one of the ways in which the organism protects the bones from calcium loss during pregnancy and lactation. And it is occasionally relevant as a blood test. There is a kind of kidney cancer that is a cancer of these cells that is called medullary thyroid cancer, and that is a component of some syndromes that are called multiple endocrine neoplasias. And I might talk a little bit more about them, but not right now. We're moving on to vitamin D because vitamin D is essentially a hormone, and endocrinologists are the people who manage problems with vitamin D. I used to wonder about that, and then I figured out that it's because vitamin D is a hormone. The active form of the vitamin D that we absorb from the diet, and the vitamin D that we absorb from the diet is called cholecalciferol, and it is converted, as is something called 7-dehydrocholesterol, which is in the skin and is converted by ultraviolet light to vitamin D3. So in the liver, the vitamin D3 is converted to a substance called 25-hydroxycholecalciferol. And you don't have to remember all of these names, but I do want you to know that in the cortex of the kidney, there is a conversion of this precursor into something called 125 dihydroxycholecalciferol, which is active vitamin D. So you need active vitamin D. Parathyroid hormone stimulates the kidney to convert inactive vitamin D to active vitamin D. So parathyroid, in the absence of parathyroid hormone, vitamin D precursors are not activated. They're converted into another inactive form of vitamin D. So if calcium levels drop and parathyroid hormone is released from the parathyroid glands, it acts in the kidneys to, in addition to causing calcium reabsorption, it acts in the kidneys to increase the activation of inactive vitamin D compounds to vitamin D to 125 dihydroxycholecalciferol. If you think about what everything on this slide says, what kind of a hormone is vitamin D? Is it a peptide? Is it a tyrosine derivative? No, it's a steroid hormone because it is a cholesterol um, component, or starts with a cholesterol component and is lipid soluble like cholesterol. So it's a steroid. In the small intestine, vitamin D promotes calcium absorption through a couple of different mechanisms. And you don't have to know the mechanisms, but know that there are a few ways in which vitamin D stimulates calcium absorption in the small intestine. This is why when we are treating osteoporosis, or when we are trying to prevent osteoporosis, we give vitamin D and calcium together. Just giving calcium is ineffective if the person has inadequate amounts of activated vitamin D. Remember that calcium is ionic, it's a cation, and it can't cross cell membranes without these mechanisms like calcium binding protein, calcium stimulated ATPase, and alkaline phosphatase. So the rate of absorption of calcium is entirely determined by these regulations by vitamin D. And phosphate ions are absorbed in a less regulated manner, but the presence of vitamin D is helpful in the absorption of phosphate as well as of calcium. So here we're putting all of this together. We have sunshine on the skin that's turning 7-dehydrocholesterol into pre-D3 and vitamin D3. We have dietary sources of D2 and D3. We have supplements of D3. They circulate in the liver. There is an enzyme that acts on them to make a vitamin D precursor, which in the cortex of the kidney is activated into active vitamin D3, 125 dihydroxy vitamin D. And that is under the influence of parathyroid hormone. Vitamin D works in the bones and is bound in bones. Parathyroid hormone causes the release of calcium from bones. Here it's acting on osteoblasts. In addition, vitamin D, activated vitamin D, acts on the intestine to increase calcium and phosphate reabsorption. Calcium circulating in the blood is going to feed back on the parathyroid glands, which I don't think this shows. And the calcium and phosphate in the blood is important for bone mineralization, maintaining bone mineralization, for lots of metabolic functions, and especially for neuromuscular function. On this slide, we can see that low calcium intake stimulates the secretion of parathyroid hormone, which increases the production of vitamin D. High calcium intake inhibits the secretion of parathyroid hormone and suppresses the synthesis of vitamin D because you need parathyroid hormone to synthesize vitamin D. When we have low calcium intake, we don't secrete much calcitonin because we have low calcium levels. When we have high calcium levels, while we're inhibiting the secretion of parathormone, we stimulate the secretion of calcitonin. When we have a low calcium intake with the increase in parathyroid hormone and vitamin D, we're going to enhance our absorption of calcium. And the opposite is true. Well, high calcium intake, a lot of the calcium just keeps moving through and doesn't get absorbed. With low calcium intake, we release calcium and phosphate from bone under the influence of parathormone. When we have plenty of calcium, we decrease the release of calcium from bone, so we don't break down bone. When we have low calcium intake, we don't excrete calcium, we reabsorb it. And the opposite is true when we have a lot of calcium. Now, renal excretion of phosphate is stimulated by parathyroid hormone. So we lose phosphate while we're reabsorbing calcium. So there'll be more phosphate in the urine. And you may remember that I mentioned that phosphate is a buffer in the urine. So there's always some phosphate in the urine. We decrease the amount of phosphate that we are excreting from the urine when we have high calcium levels. And essentially, we end up with normal calcium and phosphate through everything working together, even if over time we get bone loss. So the homeostasis of calcium is important enough that we'll sacrifice bone to maintain normal calcium levels. And the same thing is true with high calcium intake. We typically don't get super high calcium levels, although because of the mechanisms, the inhibition of parathormone production and the increase in calcitonin production and all of those things. So let's move on to the adrenal glands. The adrenal glands are also called the suprarenal glands. They sit like little caps on the kidneys and they're quite small. So in adulthood, each adrenal weighs 4 to 5 grams. They have their own arterial and venous supply from adrenal arteries and adrenal veins, and they have an outer cortex and an inner medulla. If you remember, the inner medulla is an important part of the autonomic nervous system, and it's where epinephrine or adrenaline is produced in response to sympathetic output signals. But the cortex is what we're going to be talking about now. So we have 3 important types of adrenocortical steroids or hormones. The 3 hormones are produced by layers of the cortex, and from outside to inside, they're the zona glomerulosa, the zona fasciculata, and the zona reticularis. You don't have to memorize that, but you do need to know about the 3 kinds of adrenal corticosteroids, adrenocortical hormones that are made in the adrenal cortex. Don't get your cortex and your medulla mixed up. All of these are steroid hormones. They're all based on cholesterol. The exterior layer of the cortex makes mineralocorticoid, and the main one of those, and the one we've talked about, is aldosterone, which is part of the renin angiotensin aldosterone system that we've discussed at pretty great length. The middle layer makes cortisol or glucocorticoids, and cortisol is the most important of those. And the innermost layer of the cortex makes adrenal androgens, and the main adrenal androgen is DHEA, dehydroepiandrosterone. And this is a precursor for the production of both male and female sex hormones. So DHEA is involved in making testosterone and in making estrogen and progesterone. And again, they're all steroid hormones. They're all lipid soluble. They're all synthesized from cholesterol. Cortisol is extremely bound to proteins in the blood, and there are a couple of cortisol specific binding proteins. Something called cortisol binding globulin, and its other name is transcortin. It transport cortisol. It's made by the liver, and 90% of circulating cortisol is bound to proteins, especially to cortisol binding globulin. Aldosterone is much less tightly bound, only about half of it is bound to proteins. All of these steroid hormones that are made in the adrenal cortex are metabolized and degraded in the liver and eliminated. The compounds may be eliminated through the urine, and these tend to end up being water soluble compounds, and some of them are excreted in the stool by being secreted into the bile fluid. Aldosterone, which is a mineralocorticoid made in the outermost layer, is really important in promoting the reabsorption of sodium in exchange for the excretion of potassium in the renal tubular epithelium of the distal convoluted tubule and the collecting ducts. Interestingly, it has similar effects on salivary glands and sweat glands. So aldosterone changes the composition of perspiration and of saliva as well as of urine. When we reabsorb more sodium, we reabsorb water with it. There's a passive reabsorption of water. So this increases extracellular fluid volume without changing the osmolarity or the plasma sodium concentration. When we have a lot of aldosterone and we are holding on to a lot of salt and water, and we have an elevated volume, we can have hypertension. And that will actually limit further increases in volume. There's a increase in pressure in the kidneys, causing an increase in filtration, and we get some diuresis. So this is called aldosterone escape, and it keeps excess aldosterone from causing too severe a volume overload. When there is an absence of aldosterone, the kidneys can't hold on to salt and therefore can't hold on to water, and urine volume is very high, and the individual gets very dehydrated and requires constant intake of salt and water to maintain a normal volume. Aldosterone is under the control of a few factors. We talked about angiotensin 2, right? So angiotensin 2 triggers the production of aldosterone, but there are other things. Adrenocorticotropic hormone, ACTH, which is an anterior pituitary hormone that stimulates cortisol production, also has an effect on the zona glomerulosa and triggers some aldosterone production. In addition, when potassium levels are high in the plasma and in the extracellular fluid, it triggers some aldosterone production to try to exchange sodium for potassium and get rid of more potassium in the urine. On the other hand, when sodium levels in the extracellular fluid are high, it inhibits the production of aldosterone. When we have high levels of aldosterone, in addition to the volume overload that can happen and hypertension, we can get hypokalemia because we're holding on to sodium and we're excreting potassium. And low potassium can cause muscle weakness and cramps. When we have low levels of aldosterone, we get high potassium levels in the extracellular fluid. And high potassium levels can be quite dangerous and trigger fatal cardiac arrhythmias. Because of the countertransport between sodium and hydrogen ions, we can lose excess hydrogen ions and get a mild metabolic alkalosis when aldosterone levels are high. When are aldosterone levels high? Well, sometimes we get an adenoma. And we've talked about adenomas. They are functional tumors that tend not to be under control of the normal homeostatic mechanisms and make hormone. So, an aldosterone producing hormone produces a condition called primary aldosteronism or CON syndrome, and it results in low potassium, metabolic alkalosis, hypertension, sometimes high sodium levels, and periodic episodes of muscle paralysis from very low potassium levels. And it can be treated by removing the tumor if we can find it. Ideally, we find it. But medically, we can suppress the actions of aldosterone with an aldosterone antagonist. And spironolactone is a diuretic that acts by being an aldosterone antagonist. I believe we talked about it. And it is a potassium sparing diuretic. So it lets us hold on to more potassium. And we may need, in addition, to give additional potassium to maintain potassium levels at a normal level. The glucocorticoids, primarily cortisol, also corticosterone, are produced in the middle layer of the cortex, and they have a lot of interesting metabolic effects. They stimulate the creation of glucose from fatty acids and amino acids. So they raise glucose levels. That's called gluconeogenesis. And they do that by increasing the transcription of genes and the translation of RNA in the liver to make enzymes that then turn fatty acids and amino acids into glucose. In addition, in order to do that, they need to mobilize find amino acids, so they break down muscle. And they are catabolic. You've heard of anabolic steroids, which promote growth. Glucocorticoids are catabolic steroids. They break down tissue and they make muscle smaller, not bigger. They act in opposition to insulin, and we will talk about insulin in our next lecture. And one of the things insulin does is that it inhibits gluconeogenesis. So steroids antagonize that. They increase glucose utilization. They increase blood glucose. They mobilize fatty acids just like they mobilize amino acids. And they're important in our response to stress. So getting extra glucose is getting extra fuel. But they also work on cell membranes. They stabilize cell membranes. They decrease the release of a lot of the immune system mediators and cytokines. They reduce the permeability of capillaries to prevent edema and swelling. They slow down the migration of white cells, so they actually inhibit immunity, and they decrease the reproduction of lymphocytes. So they reduce inflammation, but they also reduce immunity. So side effects of excess glucocorticoids include immune compromise, hyperglycemia, and muscle breakdown. Cortisol productions is regulated by ACTH, and ACTH, you remember, is an anterior pituitary hormone that is stimulated by corticotropin releasing hormone or factor. So CRH, CRF stimulates ACTH release, which stimulates cortisol production and release. And when we have stress, it triggers CRH, ACTH, and cortisol very rapidly and quite strongly. There is a negative feedback loop. So high cortisol levels feed back on the hypothalamus and on the anterior pituitary to drop back the production of CRH and ACTH. There are changes in cortisol production with circadian rhythms, so the amount of cortisol that we're making changes throughout the day. It tends to be highest in the early morning, shortly before we wake up, lowest in the evening. And people who have irregular sleep patterns have irregular cortisol release patterns, and that can actually be a physiologic stressor on its own. When we have excess cortisol, we can have either Cushing syndrome or Cushing disease. Cushing disease we talked about already. Cushing disease results from the overproduction of ACTH in the anterior pituitary, usually from an adenoma. But if we either get too much exogenous cortisol or cortisol-like substances, things like prednisone, or if we're making too much in the adrenal gland, or if we have an ectopic adenoma somewhere that's just churning out corticosteroids, we get Cushing syndrome. So that's the difference between Cushing syndrome and Cushing disease. The manifestations are very similar, but Cushing disease is from the overproduction of ACTH. The characteristics include something called moon faces. So people with either Cushing syndrome or Cushing disease tend to have round faces. They tend to have central obesity, so fat middles and thinner arms and legs relative to their middles. They often have hyperglycemia or even type 2 diabetes, elevated blood sugars. They may get a fatty growth on the back of the neck that used to be called a buffalo hump and is usually now called a dorsocervical fat pad. They get stretch marks, striae, and a skin condition called acanthosis nigricans, which is a dark, velvety skin change, often occurs around the neck. When there is inadequate cortisol, that's Addison disease or adrenal insufficiency. And the manifestations of Addison disease include loss of weight. These folks tend to be thin. They are weak. They are hypotensive, hypoglycemic, may have nausea and vomiting, which of course contributes further to the weakness and hypotension. And they get tanned looking, their skin darkens. The reason their skin darkens is that the lack of cortisol leads to an overproduction of ACTH because the negative feedback loop, the anterior pituitary and the hypothalamus are trying to stimulate the adrenal glands to make cortisol, and the adrenal glands can't make cortisol. And ACTH actually is similar in a molecular fashion to a hormone called melanocyte stimulating hormone that makes people more tan. So the ACTH tends to increase melanin production. These are diagrams of individuals, or a picture and a diagram of individuals with Cushing syndrome or disease, the moon facies, round face, often flushing. Women frequently get facial hair, the dorsocervical fat pad, bone loss, osteoporosis, central obesity with thinner arms and legs because of muscle wasting, often poor wound healing, hyperglycemia, abdominal striae. They may get cardiac hypertrophy and fertility issues, amenorrhea in women. Addison disease, and again a picture of JFK, and this is earlier in his life where he looks kind of skinny. If you look at pictures shortly before he was assassinated, his face is much rounder. You get hypoglycemia, hypotension, particularly postural hypotension. So stand up, blood pressure drops, get dizzy. GI disturbances, nausea, vomiting, weakness, weight loss, sometimes changes in the distribution of body hair, and this bronze pigmentation of the skin. Cortisol does have some mineralocorticoid effects like aldosterone. So when a person with Addison disease is stressed and they require cortisol and they can't make it, they get profoundly fatigued, hypotensive, dehydrated, their kidneys shut down, and they, like somebody with inadequate aldosterone, get low sodium and high serum potassium. This is a slide illustrating that crisis in Addison disease, where while all of these things are already true, the adrenal glands aren't functioning, they're not making cortisol, they're not making aldosterone, and this person is not getting enough exogenous cortisone, prednisone, or dexamethasone. Everything quits working. So the liver function decreases, digestive functions decrease, blood sugar goes way down. Vomiting, diarrhea, cramps leading to dehydration and shock, along with water and sodium loss, dehydration, and shock. And then the problems with electrolytes as well as volume, decreased cardiac output can cause irregular heart rate or arrhythmias, and again, low blood pressure, shock, coma, and death. The last layer of the adrenal gland makes androgens. So the zona reticularis, which is the inmost of the three layers of the adrenal cortex. And the adrenal androgens include DHEA, DHEAS, androstenedione, and androstenediol. The primary one is DHEA, dehydroepiandrosterone. These hormones are very important in early development and in fetal development. In the peripheral tissues, they're converted to testosterone. In women who require some androgens, the adrenal gland is the primary source of androgens, although there are some androgens produced in the ovary. And the adrenal androgens are responsible for the pubic and axillary hair growth that occurs at puberty. There are receptors in many tissues in both men and women, and we do not entirely understand all of the functions of adrenal androgens. Their production is controlled like cortisol and like aldosterone by ACTH. But there are other factors. So precursors that are available, certain enzymes, and we'll talk about those, appropriate blood supply, all of those help to control the production of adrenal androgens. And there are other things that feed in to the control of adrenal androgen production, including sex hormones, insulin, and certain growth factors. When there are problems with adrenal androgen production, particularly excessive adrenal androgen production, and this is primarily a problem in women, they get hairy. Hirsutism is one symptom, worsening acne, virilization, so even changes in the external genitalia, menstrual abnormalities, certainly infertility, and then insulin resistance that can lead to diabetes, dyslipidemias that can lead to atherosclerosis. There are also some inherited disorders of adrenal androgens. So there is something that is called congenital adrenal hyperplasia. And depending on the enzymes that are affected, that are involved in the production of adrenal androgens, you can get either high or low levels of adrenal androgens. 21 hydroxylase deficiency, which is a congenital issue, is one of the many conditions that for which there is universal newborn screening from those heel sticks. You can have excessive adrenal androgen production from an adenoma, an androgen producing tumor. But one of the things that needs to be sorted out is that women who have the hirsutism, acne, virilization, menstrual abnormalities, infertility, insulin resistance, and dyslipidemias, those are very similar to the symptoms of what's called polycystic ovarian syndrome, or PCOS. And when I was in PA school back in the 80s, that was sometimes called partial adrenal hyperplasia. And this last slide, and we will come back to this when we talk about when we talk about reproductive physiology, is a picture of the external genitalia of an infant with congenital adrenal hyperplasia. And it's ambiguous. You have a enlarged clitoris that looks almost like a phallus, rugated labia, and they are labia because there's a vaginal opening. This is the urethra, so the urethra is not in this phallus, potentially phallus. The labia aren't smooth as they would be in an infant girl, but rugated, kind of like what you'd expect of the scrotum of a baby boy. And sometimes this can create real issues for a child. They may, in a less sophisticated medically situation, end up with an unclear gender identity. Again, we screen for this, and sometimes these kids will end up having surgery to make their genitalia more consistent with their gender. And that's all we have for today. Again, we'll be coming back to congenital adrenal hyperplasia because it will help us understand some things about reproduction.